Today we'll talk about chest trauma. This is a lecture in the series of thoracic surgery for undergraduate students. So let's first talk about the mechanism of injury. The thoracic trauma might result from either penetrating injuries or plant traumas or iatrogenic traumas. So with penetrating injuries, the most common or obvious mechanism is stab wounds. It results in could result in lung injuries, hemothorax or pneumothorax, or injury to the heart or blood vessels, or esophageal injuries. The blunt injuries might result from a blow, like for example causing rib fractures, dislocation injuries, and compression injuries. The rib fracture are the most common thoracic injuries in the blunt thoracic trauma, and if there is aggressive or more forceful sort of injury, it might result in the fracture of the sternum, the first rib, or even the scapula. This is a chest X-ray showing rib fractures, and this is a compressive mechanism of injury, which might result, for example, in rupture of the diaphragm and a herniation of the abdominal content in the thoracic cavity. So we'll start by the chest wall and inside, and from the injuries of the chest wall, which might result in chest wall contusions or hematomas, rib fractures. If there's multiple rib fractures, it might result in flail chest or stove in chest. If there's bilateral rib fractures attached to the sternum, it might cause flail sternum. It could be isolated sternal fractures or fractures to the clavicle or shoulder girdles. This is a scan showing fractured ribs, and as you can see, there is a muscular hematoma. And this is a chest X-ray showing multiple fractured ribs. The lung injuries or injuries also to the pleural space might result in the pulmonary contusions or pulmonary lacerations or hematomas, pneumothorax, hemopneumothorax, or chylothorax. This is a CT scan showing the contusions of the lungs, and this is a chest X-ray showing hemopneumothorax, and this is a massive pneumothorax resulting in a total lung collapse. Injuries to the airways, one of them is tracheobronchial injuries or tears, and also there's cardiac injuries, either pericardial tamponade or contusions. Blood vessel injuries could be traumatic rupture or aneurysms or dissections or thoracic aortic injury to other structures like esophageal injuries or diaphragmatic injuries. And it is important to remember there's the thoracoabdominal injuries. So even if the injury in the thoracic cavity or in the anterior wall or posterior wall of the chest, it's important to remember that might include also abdominal organs. For example, the fracture lower ribs might result in splenic or liver hematomas, and with this also important to exclude during the primary survey of the trauma. So remember that the thoracic cavities involve mainly in respiration and ventilation. And it is a continuous mobility unlike another part of the body. And this continuous dynamic of the mechanics and dynamics of respiration is important to maintain proper ventilation and oxygenation. So if there's any thoracic trauma which might disrupt this balance, it might result in significant physiological disequilibrium and resulting in tissue hypoxia and metabolic acidosis if they are significant. The simple chest wall injuries are the rib fractures, which could be single or multiple. If they are multiple, they might result in flail chest or stove in chest. And there's also open pneumothorax if there is a large defect in the chest wall. Rib fractures, so the most common thoracic injury, and if they are forceful sort of injury, it might result in the first rib injuries or scapula or clavicle, and it's important in these structures to exclude injuries to vascular injuries like subclavian vessels or brachioplexus. And the fracture of lower ribs is associated also with intra-abdominal injuries, so it's important to exclude them as well. This is a chest X-ray showing multiple fractures, and this is also a CT scan showing diaphragmatic rupture and herniation of abdominal content in the thoracic cavity. The rib fracture could be either single or multiple, and the multiple fractures might either move paradoxically in relation to respiration, resulting in what we call flail chest, or could be pushed in and fixed, which is called stove in chest. The simple rib fractures are the result of direct and indirect violence. Clinically, the patients will present with severe pain on movement or breathing, and localized tenderness, or if there is a chest wall hematoma or crepitus on examination. With chest X-ray will show the simple rib fractures. The CT scan is not usually needed unless we are concerned about associated injuries. The important aim of treatment is to relieve the pain, because remember, these patients will have severe pain which is produced by respiration. So it is important to make sure that the patient is breathing properly, and because the patient will try to limit the movement of the chest by decreasing the respiration and also limit the coughing. So this will result in retention of secretions and risk of pneumonia, particularly in elderly patients. So either depending on the extent of injuries, either simple analgesia or like PCAs or regional blocks, so like epidural or like serratus block or electrospiny block. And the chest binders are not recommended because this will result in more splinting of the chest cavity, limiting of the effort of breathing and coughing. So the flail chest is multiple fractures, usually 2 fractures per rib, at least 2 ribs, in 2 rib segments, and this segment is moving in the opposite side during respiration. So when the lung is pushed in outside, this segment is pushed inside, and the vice versa. This is required significant force to produce the fractures on multiple segments, and it is diagnosed clinically because you need to see the segment moving in the opposite side during respiration. So the flail chest could be either anterior, posterior, or lateral. With the posterior, it could be covered with scapula, so it might not be that much severe. The flail segments is bilateral fractures of the ribs attached to the sternum. The Stoven chest is unlike to the flail chest is a fixed segment, and this is pushed inside. So the pathophysiology is there is a paradoxical motion of the flail segment in relation to the respiration, and this results in what we call fluttering of the mediastinum and result in what's pendulum respiration, and this impairs the ventilation. So if you can see here, because of the pushing of this flail segment during inspiration, the air entering the lung during inspiration is pushed to the other side, and vice versa. So this will impair the ventilation in the lung. The clinical picture of patients will have a severe pain and tenderness, and which is precipitated by respiration and movement. Also will have dyspnea and tachypnea, and will have respiratory compromise because of the impaired ventilations, and also hypotension and tachycardia. If we did a chest x-ray, you can identify the fractures, do an EBG and CT scan to identify if there's associated underlying injuries. So the main significance of the chest, however, is the indicated presence of pulmonary contusions, because this will add to the respiratory compromise and the hypoxia. So in most cases, the extent of the injury is determining the clinical course and the need of mechanical ventilation and the CPAP. So as I mentioned before, patients should be on 100% oxygen. They should have a proper analgesia, either with regional analgesia or simple analgesia, and we have to assess the need for assess the ventilation, whether this is CPAP or intermittent post-pressure ventilation or mechanical ventilation. This will result on internal stabilization of the chest wall. If the patient is retaining CO2 or being hypoxic, particularly in the elderly patients, frail patients who will not be able to tolerate hypoxia, then an assisted ventilation is needed till resolution of the pulmonary contusions, because usually pulmonary contusion, in addition to the flail segment, will result in compromise of the ventilation and respiratory mechanics. Internal fixation using orthopedic devices is rarely used. Unless the patient is, we can consider fixation if the patient is unable to be weaned from mechanical ventilation. This is an external fixation which was used in all times for chest wall injuries. That was prior to the intubation and mechanical ventilation. The other thing is open or sucking pneumothorax. Open pneumothorax is, as its name indicates, is an effect of the chest wall which causes direct communication between the pleural space and the exterior environment. And this will result, if the diameter of the wound is 2/3 the diameter of the trachea or larger, this will result in the air being drawn in the chest till the pressure is equalized between the atmospheric pressure and the intrapleural pressure, and this will result in the lung collapse and paroxysmal shifting of the mediastinum to the other side, causing tension pneumothorax. So the symptoms is, if the patient will usually have a penetrating chest trauma to cause that defect on the chest wall, you will find a chest wall which have sucking of the air with frothy blood on the one side. severe dyspnea, and hypovolemia. So in addition to the ABCs and high flow oxygen, we have to cover the side by sterile occlusive dressing, and which is taped on 3 sides and leaving one side to act as a flutter valve, allowing the air to go out instead of getting inside the lungs. And then progressive air management, and then insertion of a chest drain till definitive surgical repair and procedure is done. So this is the temporary procedure which can be done initially before an insertion of a chest drain and proper surgical management. The other injuries involving the pleural cavity resulting in traumatic pneumothorax or hemothorax or cardiothorax. So let's start with the pneumothorax. There are 3 types, usually simple pneumothorax, tension pneumothorax, and the open pneumothorax, which we just discussed. The simple pneumothorax is common after blunt chest injuries due to the fracture ribs or even plow injuries, resulting in alveolar injuries and injury to the small airways, or trachea if there's an extensive injury, resulting in the air escaping into the pleural space and causing collapse of the lung. The clinical picture is a patient having pain from the site of injury, and also will have dyspnea and tachypnea, and depending on the amount of air, the amount of air in the lung, the patient could be asymptomatic if there's a minimal air around the lung, or could have significant dyspnea and tachypnea if there's a massive pneumothorax and resulting in lung collapse. CT chest can be done to exclude underlying chest injuries. So this is a CT scan showing the pneumothorax, and this is also total lung collapse due to massive pneumothorax. The treatments depending on the amount of air and the patient's symptoms. So the mild or minimal can be treated conservatively with oxygen nebulizers and admitting the patient or having an observation. The moderate and severe will need an intercostal drain in the to decompress the pleura. The tension pneumothorax is, however, complete collapse of the lung with shifting of the mediastinum. So the patient will usually develop an obstructive shock, and that's because when the mediastinum is shifted to the contralateral side, this will cause kinking of the great vessels. With kinking of the great vessels, there is a limitation of the venous return to the heart, and this resulting also on low cardiac output, and that will eventually lead to obstructive shock. So the patient might be presented with low blood pressure, bulging or distended veins on the neck, and rapid heart rate. And that is the mechanism of how the tension pneumothorax develops. So there is a shifting of the mediastinum to the contralateral side with kinking of the great vessels. So the diagnosis is mainly clinical, and the patients have a patient presented with respiratory hemodynamically compromise, and there is a decrease in air entry on one side, and could be any evidence of injury to the chest wall, like tenderness or hematomas, or patient can also be presented with respiratory with a shock or cardiac arrest. So this is one of the causes that should be reversed during the resuscitation. Also the chest x-ray if the patient is stabilized, and then ABGs. So the treatment is in a pleural decompression, so it should be done in the initial setting before inserting a drain, and this using a wide bore needle in the second intercostal semiclavicular line, and actually in ATLS it's now in the fifth intercostal space, and then later on to insert a drain, an intercostal drain for proper decompression and drainage of air. If there is any failure of re-expansion of the lung, or if there is continuous or persistent air leak, then there will be need for thoracotomies and exploration. Traumatic hemothorax, most of them are resulting from the rib fractures or minor vascular injuries. Usually they are self-limiting if they are minors. However, if they are massive, they might require exploration. So according to the amount and the patient's hemodynamic status, there are mild up to 350 cc's, moderate for till 1.5 liters, and massively if there's more than 1.5 liters. And sometimes the hemothorax could be neglected. Either the patient have a small bleeder inside the chest, which is bleeding very slowly and building up over the time, and is neglected on the primary survey, or the patient did not seek medical advice and his hemodynamic is stable. This hemothorax will result in later infection and leading to chronic empyema, and then if not treated, fibothorax. So the diagnosis is mainly with as well as a clinical diagnosis of the patient having chest pain or tenderness at the side, or hematomas indicating rib fractures and chest traumas, as well as decreased range on that side, and also signs of shock if there is massive hemorrhage. Chest x-ray, an erect chest x-ray or standing chest x-ray is important because it helps to quantify and to confirm the diagnosis. And when the patient is in a supine position, or the x-ray is not very accurate to determine the amount of the hemothorax and to confirm the diagnosis, because it will appear as a homogeneous opacity all over the hemothorax. Also, the FAST is a bedside helpful tool to diagnose quick diagnosis for small hemothorax, which is less than 200, which is not very big, which is not well picked on the chest X-rays, and also the CT scan to exclude other injuries. This is chest X-ray showing a hydropneumothorax or hemothorax, and also here is a chest X-ray showing hemothorax. So in the supine position, enough fluid is visible because the chest X-ray will have a diffuse opacification, so it's better to do a standing chest X-ray. And as I mentioned, the FAST scan is helpful to detect smaller hemothoraces, and the computed tomography is also more sensitive than the plain chest radiography in diagnosing hemothorax. So the management is either minimal, then we do conservative management. If it is mild to moderate, we can do aspiration. Of the severe or moderate collection, then we have to insert a chest drain. And thoracotomy is indicated for patients with massive hemothorax with continuous drainage from the drain with initial 1.5 liters, or a continuous hemothorax, or a neglected hemothorax, which can be done electively in the patients developing chronic empyema or fibrothorax. Chylothorax is another injury to the thoracic duct, which might occur at any level of its course. The chyle drainage is persistent through the intercostal tube, and it usually appears as a milky drainage. So the treatment is initially a conservative treatment. So we have to monitor the output of the drain to that will direct management. Usually patients with high output, like 1.5 liters or more, will have unlikely chances of success of conservative management, and we have also to do challenge tests to make sure that if the drainage is stopped, there's no continuous or minor injuries on the thoracic duct. So the conservative management is nothing per oral, and patients should be given TBNs, fat-free and medium chain fatty acid supplements, as also antibiotics, and improve their nutrition. He will need a nutritional assessment to also make sure that he's receiving the essential nutrients, and to improve his nutrition, because usually chylothorax is associated with will suppress the immunity of the patients. If the patients have a high output or the drainage is continuous over 2 weeks, in some centers even less, the patients will have to undergo a mass ligation of the thoracic duct. Sometimes it is aided by giving the patient like a fatty meal, like a cream or any diet containing fat, to help to visualize the thoracic duct during surgery before doing a mass ligation near the hiatus in the diaphragm. The lung injuries may range from contusion, which is just a small rupture of the alveoli, and with a small extravasation of blood, and this will appear as patchy GGOs or parenchymal opacifications, and could have diffuse opacification. The treatment is mainly supportive. There's no surgical management, supportive treatment with antibiotics, and if the patient developed pneumonia or ARDS, then ventilator support. The lacerations are more of penetrating injury causing hydropneumothorax, because the lung will there will be some air leak and also blood extravasation. The treatment in this case is intercostal drain. If the patients have a prolonged or persistent air leak and failure of the lung to expand on the subsequent chest X-ray, then the patient is indicated for exploration, either vasotracheotomy, and then repair, stabling, or suturing of the lacerations and lung tears. The hematoma is more of a localized collection inside the lung parenchyma, appearing as more well-defined, opacified appearance in the chest X-ray. The treatment is mainly conservative with antibiotics and to support against the secondary infection. So let's move to the mediastinal traumas. And the first thing is a traumatic asphyxia. Traumatic asphyxia occurs when there is a compressive forces applied to the thorax with a closed glottis. And in this case, there will be a venous congestion from backward flow of the blood from the right side of the heart into the superior vena cava and the upper extremities. So the patient will have engorged and swollen head and neck, and there's a rupture of the small capillaries in the eyes and in the conjunctiva, causing conjunctival hemorrhages, and also swelling of the face and tongue. There's no respiratory related symptoms, it's just more of the venous engorgement. The treatment is mainly conservative with care of eyes. The second thing is pneumomediastinum. Pneumomediastinum is the air in the mediastinum, and the main important thing is that it's the pneumomediastinum, it's by itself is not life-threatening. However, we have to identify the underlying cause, whether it is a rupture of the tracheobronchial tree, whether it is an esophageal rupture, or a complicating pneumothorax. And that is a picture of a surgical emphysema in the neck. And usually in the chest x-ray, you will find air in the mediastinum surrounding the heart, and also the treatment would be treatment of the cause, usually by treatment of the underlying cause, whether it is an esophageal rupture or in a tracheobronchial tree injury. Treatment of the cause will result mainly on the resolution, because it will just take some time. Some patients might benefit from a massaging or hot fomites or subcutaneous drains. During examination, you can find what's called Hammond signs. Hammond signs is a crunching sound with each heartbeat, because the air is crushed with each heartbeat. So the second thing is the tracheobronchial injury. Most lacerations occurring within 2-3 centimeter on the carina, and resulting in the mediastinal or subcutaneous emphysema and pneumothorax. And if it is a major airway, it might result in massive air leak. The patient may be in respiratory distress. So the treatment is a bronchoscopy to localize the tear, and then it will require immediate repair. The second thing is esophageal injury. Esophageal injury is serious because sometimes it's neglected in the first assessment, and by esophageal injury, if the patient started to have feeding, or even if the patient didn't start have feeding, that might result in chemical irritation to the mediastinum, and it results in fulminant mediastinitis, and mediastinitis carries high morbidity and mortality rates. And so the patients will have the air entering the mediastinum as well as the chemical substance, and if the patient started to have food as well, that will result in infection and spreading of the infection. So the treatment should be primary repair with adequate liquid drainage if this is picked up very early, and if it is not directed early, then patient might have also mediastinal drainage or feeding gastrostomy and genostomy, allowing the esophagus to heal if it is a small injury. And then later on resection and second stage reconstruction using stomach on colon when the patient's state is stabilized. Diaphragmatic injury is requiring a high index of suspicion, because patients who are presenting later with volvulus of the intestinal content in the chest, they usually report that they have an injury to the chest in the past. So this indicates that the diaphragmatic injury was not detected in the first instance. So it's important to detect the diaphragmatic injury, particularly if there is an injury to the lower chest, lower ribs. The patient will be presented usually with dyspnea or lying down, because at this time when lying down, the intestinal contents will be pushed inside the chest. Might also have cyanosis, and by auscultation you might be able to listen to auscultate the bowel sounds. So diagnosis with nasogastric, if you insert a nasogastric tube and then a chest x-ray, then you can find the tube in the chest, and you can also do a chest x-ray or to do a CT scan to ensure there is no diaphragmatic rupture. So this is a CT scan or chest x-ray showing the content of the abdomen inside the chest, and that's also the stomach inside the chest. So usually it is resulting from the rapid deceleration. So the treatment will be nasogastric decompression to try to reduce the size of the stomach in the chest, try to get it back to the chest, and then avoidance of intercostal drain, because this is a high risk of injury to the stomach, which will result in massive complications and will result in mediastinitis in the same time as well. So it's important then to avoid the intercostal drain and take the patient to have laparotomy, and then laparotomy will result in laparotomy to repair the diaphragm and then reduce the hernial contents and bring them back to the abdomen. They also can result from acute penetrating injury, and the diaphragmatic defect is small. Immediate herniation is rare. So if it is a small injury, if it's a small defect, usually the abdominal viscera will not be able to go instantly inside the chest. So the treatment, if detected early, is to repair also from laparotomy. In patients with chronic diaphragmatic hernia, so they are missed in the first instance and they neglected, and patient is presented later with complications following like incarceration or volvulus or intestinal obstruction, then they will have to undergo repair, and this time it should be thoracotomy because there'll be adhesion inside the chest, and it is not safe to reduce the content from laparotomy without assessing the viability first, because doing a laparotomy in the chronic diaphragmatic hernias and trying to reduce them is risky. So we have to start with thoracotomy to free the adhesions and assess the vitality of these organs, and then do a laparotomy to do, if needed, to do the resection or reconstruction depending on the case, if the patient is presented to complication or not. So this is a repair of the diaphragm. Cardiac trauma. So as you know, the right ventricle is occupying most of the anterior part of the chest. So it is the part of the heart projecting into the anterior chest wall. If there is a precordial injuries on the area of the precordium, then overlying the right ventricle is most vulnerable for injury. So any lacerations of the cardiac chambers will result in cardiac tamponade and bleeding in the pericardial sac. So this usually require direct operative repair. If patient have a contusion from plant trauma, it can be managed as a myocardial infarction. Patient might be presented with some dysrhythmias, arrhythmias, and it's important to exclude other injuries in other vascular injuries. And if it is the only thing presented, then patients can be treated conservatively. Septal defects and valvular injuries will have an immediate surgical repair. Injuries to the aorta and other vessels are also repaired by cardiopulmonary bypass. That is an injury to the heart. The pericardial tamponade is a sort of an obstructive shock, limiting the diastolic filling of the heart, because the pericardial sac is a small and narrow space, and the heart is unable to distend properly if it is filled with blood. So small amount of blood, even 200, might restrict the heart ability to distend properly during the diastole. So this will limit the diastolic filling, and this will result in low cardiac outputs. The patient will have then shock. It is a very high mortality rate, particularly if not detected very early and taken to theater very early. And even removing small amount of blood might result in temporary relief. So sometimes the pericardiocentesis might be done till definitive operative repair is available. Patient will have dyspnea and cyanosis and will present with what we call Bick's triad, which is important. So this will result in the triad of jugular venous distension, distant heart sounds, and hypotension or narrow pulse pressure. There's also Cosmal sign, which is decreased or absence respiratory inspiration, distension during inspiration. There's Balsam paradoxus, which is drop in the systolic blood pressure more than 10 millimeter mercury during inspiration. And there's also some arrhythmias in the ECG. So the treatment is resuscitation, pericardiocentesis, till taking the patient. The definitive procedure is surgical repair, so surgical exploration, whether sternotomy or thoracotomy, to relieve the pericardial tamponade. So thoracotomy in the chest trauma, what's the type of indication? First, the resuscitation thoracotomy. Usually it can be done on the scene or in the emergency room before the patient is unstable to get to theater. If the patient has a witness or have a cardiac arrest, then we have to do an open cardiac massage. So this is a left enterothoracotomy or clamshell if needed. Emergency thoracotomy is done in the operation room if the patient have a cardiac tamponade, if the patient have a massive hemothorax, which is more than 1.5 liter initially, or 200 for 3 hours, or having tracheobronchial injury or great vessel injury. Then elective thoracotomy if the patients have diaphragmatic repairs or patients with clotted or neglected hemothorax. And that's in the lecture. If you have any questions, please let me know. Thank you.